Good evening, friends. Uh, I am Shrenik Shah from Ahmedabad, currently in my 26th year as a vocal cord cancer survivor and patient ambassador of Indian Cancer Society, Delhi branch. Delhi branch. Today, I am having a fascinating pleasure to introduce a very highly competent and really a down to earth head and neck cancer surgeon. But before that, I must tell you that you should be lucky if you come across God's message. So, as I said, meeting or coming across God's messenger is always a privilege, and that's what I get 26 years ago. I think Dr. Kaustubh Patel sir is not seen.
Shrenik bhai, I'm here. Am I audible?
Okay. Yeah, absolutely. So, sir, uh, let me welcome you with this.
Thank you so much.
Friends, Dr. Patel, and we proudly call him as a Dr. KDB sir in Ahmedabad, and is a very prominent, highly skilled head and neck cancer surgeon, having a vast experience of over 30 years, and currently is a director of HCG Aastha Cancer Care Society, Cancer Care Hospital, and also the chairman of Apachenos fellowship program, and he has delivered numerous number of papers. And if I have to describe his journey, I think Dr. Patel will not get chance to speak at the today's event. But let me share something which is not available on a Google or on any web platform. Uh, Today I am here because of Dr. Kaustubh Patel. He is my real life savior, and I would say he has given me a new birth or life to 26 years ago. And not only that, the device with which I am speaking now, that was suggested by him, that speaking that device made me a global auditor, uh, patient ambassador, and whatnot. So no, I really have no words to express my gratitude to Dr. Kaustubh Patel. Few more things is, apart from being a cancer surgeon, is what I've learned is a laser focused head and neck cancer surgeon, and on top of that, I must say, is like a New York City in this sense. is always available for supporting head and neck cancer patient anytime required. You are outside outside in head and neck cancer, it's too polite to say, please don't ask me because I cannot guide you at any point of time. So this is his journey. And last but never the least is skating champion of Gujarat State. And when he's in the round at the cancer hospital, literally his team members they have to run behind him to catch up. So this is all I will have to say about Dr. Patel. And yes, whenever I have called him, it's so much on the rush that whenever I have called him to meet him, instead instead I ask him time, he has always asked me like what time you want to come. So this is Chandra's nature and a wonderful human being with an incredible smile. Sir, now that is all over to you.
Thank you so much, Shrenik Bhai. I know you have a very special bias and a bond with me. So uh, you will always speak from your heart when you are talking about me. Thank you. So let's focus to today's topic. Let's first, so this is for thyroid cancer. This talk is for thyroid cancer. So let us first know what is thyroid. So if you see this, you can see a butterfly shaped gland which is there in our neck. In the center of the neck, this gland stays, which is known as thyroid gland, and it surrounds the trachea, which is known as windpipe, and the voice box. So you can see this windpipe, which is surrounded by the thyroid gland, and this is the voice box, which is also surrounded in the lower portion by this thyroid. So once we know what is thyroid, what is its function in our body? Thyroid secretes thyroid hormone. Now, these thyroid hormones, popularly known as T3 and T4, this thyroid hormone is a hormone which is essential for our body's functions, lot of functions and growth. If the thyroid is secreting less, then you need to support it by some thyroid replacement hormone tablets. And if it is functioning more, then you need some medicines or some other treatment to reduce the secretion from thyroid gland, which is the root cause of more thyroid hormone in your body. And both is bad. Too much of thyroid hormone is bad for the body. Too less of the thyroid hormone is also less for the body. But when we talk about thyroid cancer, we must understand that thyroid cancer does not derange thyroid function, meaning that even if you have a huge cancer in your thyroid function test may be totally normal. So popularly, people feel that my thyroid hormones are normal, I don't have a cancer, or I don't have a problem with thyroid. That's not true. Thyroid function is only the reflection of the function of thyroid, not the structure of thyroid. And thyroid nodule and thyroid cancers are the structural problem with thyroid. Which are the type of thyroid cancer? So there are major 4 types of thyroid cancers. The first one, which is having the best prognosis, is well differentiated thyroid cancer. The next one, which is known as medullary thyroid cancer. So medullary thyroid cancer is a cancer which is having a bit poor prognosis than well-differentiated thyroid cancers. And the third one is anaplastic or undifferentiated thyroid cancer, which is the worst thyroid cancer. And in well-differentiated thyroid cancer, there are two types. One is known as papillary thyroid cancer, another is known as follicular thyroid cancer. So papillary thyroid cancer and follicular thyroid cancer. The next zone is medullary thyroid, and the third zone is a anaplastic cancer. Now, we all know good, bad, and ugly. Well-differentiated thyroid cancer, which are papillary cancers and follicular cancers, are good cancers. Medullary thyroid is a bad cancer, and undifferentiated or anaplastic thyroid cancer is the worst cancer, because when we say cancer and good, we must understand why we say cancer and good. All cancers are bad. Popularly, we all feel that cancers are bad. But amongst this cancer, there are some cancers like well-differentiated thyroid cancers, which are good because there is a 99% cure rate. That means that out of 100 patients diagnosed with this papillary or follicular cancer, 99 are cured. So that's why it is known as a good thyroid cancer. What is the incidence of thyroid cancer? So this cancer is increasing in the world. The incidence is increasing throughout the world. And so much so that the highest increase in thyroid cancer is in the world. And when you compare with other cancer, there are many cancers which are on decline, but thyroid cancer is on rise. And if you compare all the cancers which are on rise, the incidence is on rise, thyroid cancer tops it, meaning that it has the highest rate of increase in the incidence. Now, when we say that there are more and more thyroid cancers, what about people dying out of it? When we say before 30 years, how many patients die of thyroid cancer? Before 20 years, how many died? Before 10 years, how many died? And today, how many are dying? The rate is same. It is 1%. 1 to 2% of patients die of thyroid cancer. So though the incidence is increasing, people are not dying because of it, because they are managed well, and there are some other reasons why. So let's look at these other reasons why patients are not dying of thyroid cancer. Before 50 years or so, one of a brilliant autopsy surgeon started in New York, started picking out thyroid glands from people who had died. It's known as autopsy study. Means that the people who died, when their post-mortem was done, he removed the thyroid and tried to examine those thyroids. And he could see that all the people who died after 50, 60, 70 years, more than 10 to 20% of people had thyroid cancer in their thyroid. But they did not die of thyroid. It was just an incidental finding on autopsy. So there are many more studies also happened after that. And it has established that there is a incidental thyroid cancer in a patient. And if you try and look at all the thyroid in all the people, you will find some people having thyroid, but they will not get this thyroid cancer detected throughout their life. So that's the reason why the scientists started thinking that what is this? Why so much of incidence? People are not dying and they are not even detected. So then they went into this type, which is papillary and follicular. They realized that this is a very indolent cancer, meaning that it will surface in you, and even if it surfaces in you, it is still curable. When I was in US doing my fellowship, one of my thyroid surgeon mentor used to say that if everyone lives enough, they will either get thyroid cancer or prostate cancer. Meaning that if you live long, there will be some thyroid cells which will change into cancer, but these cancers are very curable cancers, extremely curable cancer. And since the mortality is same, it means that the treatment of thyroid cancer is extremely effective. And that's the reason why, though the incidence has increased, the mortality has not increased. Now, why surgery of thyroid is difficult? The reason is that thyroid surrounds this windpipe and voice box. And the nerves which goes from here and here between the windpipe and thyroid to supply the voice box, the vocal cord nerves, which moves the vocal cord, they go from behind the thyroid. So during the surgery of thyroid, you need to see to it that these nerves don't get injured. If they get injured, the voice changes, the vocal cord paralyzes. So that's the reason why surgery of thyroid is a specialized surgery. So much so that it has been said that the complication rates are extremely minimal in a high volume thyroid center, meaning that the center where lot of thyroid surgeries and parathyroid surgeries are being done, that center will have less complication compared to somewhere where it is done very occasionally. Now, what are the other risks when you do thyroid surgery? The other risk is parathyroid. Parathyroid glands, there are 4 glands in our body which are there behind the thyroid. 1, 2, 3, 4. There are 4 parathyroid glands which are behind the thyroid, and this parathyroid gland controls the calcium and phosphorus metabolism. The calcium, basically, the calcium control of the body is with parathyroid. It will decide how much will stay in the blood, how much will go in the bone, how much will go in the kidney, how much will go in the urine, and how much will go in the other parts of the body. And it controls through parathyroid hormone. Now, these 4 parathyroid glands are not absolutely necessary. Even 1 gland is enough for our body. As you know, if there are 2 kidneys, 1 kidney is not functioning, patient doesn't die. People live with 1 kidney. Even the transplant is done with 1 kidney transplant, and people live long. So that way, out of 4 parathyroids, if you have only 1, it is all right. During this thyroid surgery, the expert thyroid surgeons preserve all the 4. But during surgery, there might be some disturbance to their blood flow, and that's why temporarily there can be some parathyroid hyposecretions. Due to that, you need some calciums during your perioperative phase. But if all the 4 parathyroids are removed, then you have a lifelong problem of having no parathyroid hormone in your body, and you have lot of other symptoms. So that's the reason why in thyroid surgery, preservation of both the recurrent laryngeal nerves and all four parathyroids are extremely important. Now, what is the other issue with thyroid surgery? The other issue with thyroid surgery is the scar. When you put a small horizontal incision to remove this thyroid, it is usually put on the skin crease in the neck so that if it heals well, it doesn't show. But if it doesn't heal well, there will be a keloid formation, there will be a hypertrophy, and people can from far also realize that you have a scar, some surgery has been done. To avoid this, there are technologies by which this surgery can be done without putting a scar on the neck. Now, when you say you don't put a scar on the neck, you have to put a scar somewhere because your instrument has to go in from somewhere to remove that thyroid. And that's the reason why robotic surgery, you put an incision behind your ear in this hairline. And from there, the instrument goes to the thyroid, and with robotic arms, this thyroid is removed, and then the incision is closed. So the scar is in the hairline so that it doesn't show. The same way, there are techniques by which people do through mouth in a very small thyroid tumors. We can do it through mouth and remove it so that the scar doesn't show here. But it has to go through mouth, so there has to be a scar in the mouth. There can be a axillary incision, a scar in the axilla from where the robotic arm goes and remove the thyroid from the neck. This is also possible. All these approaches are just to avoid the scar in the neck. They do not have any more advantage over a thyroid surgery through the neck. However, those people for whom it is extremely important not to have an incision on the neck, all these technologies can be useful and you can remove the thyroid nodules. Now, removing thyroid cancer through all these approaches is still, I would say, in some part experimental. In a very early small cancer, it can be done, but otherwise, it is still experimental. Now, we talk about the types of surgeries, how you remove this. Now, if you consider 100 thyroid nodules, meaning a lump in thyroid, a nodule in the thyroid, if there are 100 patients, 90 of them do not have cancer. They are benign nodules. Only 10 have cancer. So how you know whether your nodule in the gland is cancer or not? So for that, what you need to do is an ultrasound, which will detect you have one nodule, more nodules, what are the characteristics of nodule, whether there are more chances of cancer, whether there are less chances of cancer. And then you stick a small needle, which is an injection needle, which we usually, whenever we take an injection, like, whenever you take even the COVID vaccine, it's that kind of an injection needle. The needle goes into the thyroid, into that nodule, brings out some cells. And these cells are seen with special stains under the microscope. And the pathologist can say whether there is a cancer, whether there is no cancer, or third type of report where they say that there is some probability of cancer. Maybe 15% chance of cancer, maybe 30% chance of cancer. Now, on these reports, the thyroid specialist counsels and tells what are the chances of cancer and what treatment needs to be done. Now, if somebody with a 15% or 30% chance of cancer still would say that I don't want to do surgery, then there are some molecular tests now available where these slides are sent for those molecular tests. And if those molecular tests says that there are 90% chance of this being benign, you can observe. If it says there are 90% chance of this is cancer, then you operate. So there are more and more precise technologies available to find out whether it is cancer, whether it is not cancer, or whether there is a high or low probability of cancer. And then the call is taken according to that. Now we can talk about types of surgeries. Like you can remove half of thyroid, you can remove full of thyroid, you can remove the lymph nodes around, you can remove the lymph nodes lateral to it. So there are different type of surgeries depending on the findings on CT scan and the clinical examination. There is one major treatment which I must talk about and which is known as radioactive iodine. Usually in thyroid cancer, radiation, in well differentiated thyroid cancer, radiation and chemotherapy are not effective. They are not given. The patient needs only surgery. Most of the patients need only surgery. Few of them need radioactive iodine. So what is radioactive iodine? Radioactive iodine is a radioactive material which is tagged to iodine. And in our body, even if you put a small milli drop of iodine, it is taken up by thyroid. Body's other part will be devoid of that. The thyroid will suck that iodine to itself. So if you tag the radioactive material to it, it will release the radiation at that point where there is a thyroid cancer, and it will eliminate all those cancer cells and cure the patient or have a fruitful remission. So that's why radioactive iodine treatment is a very good treatment for these kind of cancer patients, and it is highly effective. Now, this treatment only occurs if you have removed the entire thyroid, and then if there is a cancer anywhere, then that radioactive iodine will go to those parts and will kill cancer cells. But if you have an intact thyroid, the entire radioactive material will go to thyroid only. It will not go to the cancer at the other places, and the patient will not have any effect. So whenever you want to give radioactive iodine, you need to remove the entire thyroid surgically. So that is regarding the surgery. Cure rate, as I said, in the tune of 99%. So much research has been done that this is the only cancer where there are so many types of cancers in papillary and follicular cancers. There are so many subtypes. One of the subtype, which was known as NIFT-P, this was considered cancer before 10 years. But according to the data, they could see that none of the patients of NIFT-P died of thyroid cancer in the world throughout so many years. So they realized that we should not consider this as cancer. So WHO and all the cancer institute in the world united and decided that now onwards they will not call NIFT-P as thyroid cancer. So one of the type of thyroid cancer is now eliminated from the list of cancer and is considered as a benign or a high risk situation rather than cancer. So this is something which is unbelievable. Today, so many years, none of the disease has been declassified as not cancer, and previously which was considered cancer. So that is the reason why I say that this is a highly curable cancer. Now, the science moved beyond this. there is something which is known as micropapillary carcinoma. Micropapillary carcinoma means the follicular or papillary thyroid cancer which is less than 1 centimeter. When they started looking at it in Japan, there was a very good institute where they started observing these patients who had less than 1 centimeter size of papillary cancer in their thyroid. They did not operate them. They did not give any treatment. They just came on as follow-up. And they could see that more than 90% of patients did not have any increase, and they did not require any treatment. They lived normally with this less than 1 centimeter cancer. Those who progressed, those who had some changes, they underwent surgery and they are also cured. So now in today's time, micropapillary cancer, though the cancer has been diagnosed, patients have options of observing it and not getting it operated. Now, having said this, you must know that you are being observed or treated by a thyroid cancer specialist, because not all micropapillary cancer are not dangerous. There are micropapillary cancers who needs upfront surgery, and you have to separate them from those who can be observed. So these in nutshell is thyroid cancer, which is highly curable. So treatment is much easy to tolerate because it is surgery. Once you are out, you are absolutely normal. And even if you need radioactive iodine treatment, it is a treatment of 1 or 2 days only. There are no injections, there are no radiation. It is just a radioactive iodine is a liquid or a capsule which needs to be taken up. So that's why it is very user-friendly treatment, and these well-differentiated thyroid cancers are highly curable. I think with this, I'll stop. Shrenik, can we have some questions if somebody has it, or you would like to ask me? Shrenik, your microphone is mute.
Sir, may I ask?
Yes.
This is not really, first question is not about the cancer per se of thyroid, but I'm asking, I want to know that these days, every third person is having thyroidism as a disease, which is managed by a thyronome or thyroxine or whatever by the endocrinologist. What is the reason that these days the incidences of the disease are so high?
So, overall, our lifestyle, the pesticides, chemicals in the food, the pollution, everything is extremely important. These thyroid cells are prone to damage. And that's the reason why we are getting more and more hypothyroidism. We don't see many hyperthyroidism. We see more and more hypothyroidism.
Yes, yes.
And that is the reason why. And it also is obesity, diabetes, everything combined is the cause of we seeing more and more hypothyroidism.
So what dietary sort of, how can it be managed with the dietary conditions? The disease per se, not of cancer. What is the main component of the diet which causes thyroid disease?
So, it's known as certain type of cauliflower, cabbage, the broccolis, certain type, not all. It can cause hypothyroidism. It can cause thyrotoxin. But But as general, the food, the vegetables or the fruit which you get, you must clean them properly before utilizing them.
It's more of
And
adulteration in the food that
yeah,
comes.
more of adulteration. And that you have to take care. That is one thing. And then I would also say that there are some meditations and yoga, which is extremely important. It has an effect on your thyroid.
Right. Thank you.
Welcome.
Sir, thank you very much for elaborately explaining the, I would say, entire encyclopedia of thyroid cancer in last 25, 30 minutes. And, there are people, they hardly know what exactly is all about thyroid cancer. Now, I have two questions, sir. What are the probabilities of recurrent thyroid cancer after the surgery? That is my first question.
So, if an appropriately done surgery of thyroid, the recurrence rate is between 5 and 10%. But there is a caveat. Even in these 10 patients, if they are treated properly, 9 of them gets cured. So even with recurrence, the cure rates are very high.
Right. One more question. Why thyroid cancer is much more in a female than male?
Yeah, so if you consider all over the world, all other cancers, there is a male predominant. Those cancers which occurs in male and female both, there is always a male preponderance. But thyroid is the only cancer where there are more female than male. And the reason still is not exactly known. They postulate that it might be related to the female hormones and the receptors, but exactly nobody knows. It is still a mystery.
Thank you. Sir, one more question. As a competent head and neck cancer surgeon, and you perform so many thyroid cancer, I mean, when you are when you are being asked by the patient to whether to opt for the surgery with this car or with the robotic, what would you strongly recommend?
So, it all depends. Say, like I have some celebrities coming at my place with thyroid nodules, some young girls coming with a thyroid nodules where I can't observe them, I have to operate them. In those kind of situations, there is an option. But given a choice, if the scar is not an issue, I would do an open surgery. So it all depends ultimately on the psyche of the patient. What patient wants. What is right for that patient may not be right for another patient. So that's the reason why there are somebody like you and me would say that, sir, I don't want all those invasive things coming out of so many other places. I just want you to remove this. I don't mind. Most probably the scar is not going to be seen also because it is in the skin crease. But even if it shows, I don't mind about it because it doesn't matter. But then some film star, some celebrity, some young girls, they might are very much concerned about it. In those patients, we do robotic. So it's not that I have not done I have done robotics, but I have done it only for a person who really wants it.
Sir, with this card surgery is the plastic surgery is not the better option. I mean, instead of going for a, long robotic surgery.
No, it is, I mean, surgery removal results from surgery point of view are same. Only you are putting a scar over here, or you are putting a scar over here, or you are putting a scar in the mouth, or you are putting a scar in axilla. So you are shifting the location of the scar. Now, the disadvantage is that when you shift it from here, anywhere, you have to work through those place up to this place. So you have to dissect more. So these are known as remote access maximally invasive surgeries. These are not minimally invasive surgeries. So that's why, as I said, I counsel patients, I give them options, and I want them to decide after knowing that the advantage is only that scar will not be there in the neck. That is the only, and this scar is also closed with the plastic sutures. Plastic surgeon closes it. So the chances of it being shown are very less. So most of the people would decide to get it done over here. There are very few people who would tell me that, sir, I want robotic through this area, and then I do it by that. I respect that choice.
Sir, one more question again. What is the success rate between scar surgery and robotic?
What is the
Success rate of the
success
surgery?
rate are same? Success rate are same, absolutely same. Then only you can offer. Otherwise, you can't offer. So success rate are same. But you need a very experienced person for robotic surgery. You have to be a robotic surgeon to do this. You can't experiment with your patients. Like somebody who has not done robotic or who has done very few robotic should not venture into this, because that can give inferior results than the open surgery.
Great. Vishali,
Sir, what are
can
the
you
incidences in a younger age of this cancer?
So they
Uh,
are less.
hmm.
Younger age, they are less, but they are not known. And they are not unknown. I mean, I have operated as young as a 12-year girl with thyroid cancer.
So it is a case of childhood cancer also,
Yeah,
thyroid
yeah. So
present.
it is possible. Now, one of the young boy who was operated at 11 years, before I think 30 years, has now married, and now he has a kid who he brings that kid with him, and he's part of our 10 on 10 book, where uh, Shrenik is also there. You know, the 10 on 10 book. Shrenik, if possible, please present it to Aruna madam, that book.
So,
Right.
like any other cancer in this also, and the risk factor in that childhood stage is not known.
Yeah, so you know, for thyroid cancer, there is one known fact which was there since years. It's not in India, but it is there, which is known as low dose radiation exposure. What
Okay.
happened? What happened in Hiroshima and Nagasaki?
Yeah.
For years together, the children started having thyroid cancer. For years together. And the same
Like
thing has happened in Chernobyl, in the radiation outbreak in Russia. There also this incidence is known. So low dose radiation can cause thyroid cancer, and especially in children.
right.
Fortunately, at our place, it's not there, and so our children are much safe.
That's right.
So I
Thank
have
you.
a question. So I have a question. Sir, do
Yeah.
the people who have hypothyroidism or hyperthyroidism in their life, they are more susceptible to have thyroid cancer later in their life? They have more chances of
No,
getting thyroid cancer?
no. Of
Sir,
course, you should be very careful, and you should be regular in your examinations and follow up. But that doesn't mean that you have a high risk of developing cancer. The
so as
risk is
you said
almost
that
the same.
Sir, as you said that the thyroid gland functioning does not be affected with the cancer, then what are the early symptoms? Just nodules, or what?
Yeah,
How
the
we can?
early symptoms are nodule in your thyroid. They are the early symptoms. Late symptoms are voice change. Late symptoms are multiple nodules in the neck. Late symptoms are due to its effect on breathing, its effect on swallowing. They are late symptoms.
Sir, my other question is also, does the hyperthyroidism, which is also known as the autoimmune condition, it is also related with the lifestyle factors, or it is just genetic, or it can be corrected, or it can be prevented?
So let me tell you, I am not an expert on hyperthyroidism. I am an expert on thyroid nodules and thyroid cancer. This answer should come from an endocrinologist. They are the
Okay, sir.
people
Thank you.
who are slated to best treat hypo and hyperthyroidism, right?
Thank you, sir, for the wonderful session. It is a wonderful session. Thank you, sir.
Thank you so much.
Dr. Saab,
Uh,
tell me
I
one
have a
thing.
question.
Can you go for your dental checkup? They do X-rays. They always put a sort of shield there, that lead
Right.
apron around this thing. Does this really affect that short duration of the X-ray radiations?
No, no. If you have shielded your thyroid well, it doesn't affect. But you
No,
must shield.
if you don't, normally the dentists don't do that. You have to tell them, those who are aware of it, they ask you and they say, ma'am, uski wajah se aapka X-ray ठीक नहीं आ रहा, ये नहीं हो रहा. But otherwise, people, they normally don't put it when they do some cavity checkup or whatever X-rays they do.
No, I think you must put it.
Ask them to do it.
Ask them to. Yeah, you are absolutely right.
Thank you.
Sir, thank you very much for, yeah, if somebody wants to ask, yes, please proceed.
Yes, sir. Thank you, Shrenik sir. Sir, I have a question. Are there any genetic factors associated with thyroid cancer?
Yeah, so there is one type of thyroid cancer which I said bad cancer, which is medullary thyroid carcinoma. So medullary thyroid carcinoma, which is a cancer which has a genetic link. Now, not all medullary thyroid cancers, there are sporadic thyroid cancer and there are familial medullary thyroid cancer. So the familial medullary thyroid cancer has a link. So whenever somebody has a medullary thyroid cancer, they must get their genes checked for this cancer, and their first hand relatives, meaning and brother, sister, daughter, sons, they also should get the link checked.
Okay, sir. Yes. Thank you, sir.
Vaishali, please check if nobody is having any question else. We can conclude the session.
I have a question. So, hello, I have a question.
Yes.
Is there any kind of screening done for thyroid cancer?
Sorry, any kind of?
Screening.
Screening. Okay.
Yes.
This is a wonderful question. This is a wonderful question. So, as I told you, this well-differentiated thyroid cancer are highly curable cancer and the incidence is increasing. In Korea, before 20 years, they started screening the population for thyroid cancer. They started doing ultrasonography of neck to everyone. Even somebody who is walking on the street will get a neck screened. And they started finding lot of thyroid cancers. And they started operating them. Then after 10 years, they published their data. And then the world started looking at it. And then they made them realize that it is not that you have more cancers. These patients had cancer, or these kind of people can have cancer, but it may not surface for their lifetime. So the physicians in Korea made a statement with government that routine screening for thyroid cancer is not to be done. Okay, so that's why this is one cancer where the doctors will advise don't get screening. Get it done if you have some problem. Otherwise, don't do it. Because if you find a 1 millimeter or a 2 millimeter nodule, and if you poke a needle, and if it might give you a report of cancer, for that you will be so much worried that you will undergo an unnecessary operation. So that's why less than 1 centimeter of thyroid nodules, the international guideline, including Indian guidelines, says that you are not supposed to put a needle into it. If tomorrow you undergo a thyroid neck screening, and if you have a nodule which is say 5 millimeter, your doctor, if he advise you to put a needle for diagnosis, tell him, doctor, according to the guidelines, this is not indicated. I will not get it done. If the nodule is more than 1 centimeter, then yes. But don't let unnecessary thyroid cancers be diagnosed. Okay? I hope I answered your query.
Thank you. Thank you very much.
Welcome.
Sir, thank you very much. Let me add one point here who has joined later on this particular session. Dr. Patel is my savior, and because of him, I am here today on this planet, and even I am speaking like this. So he rather manifested my life to zero as a speaker, and I don't know words to express my gratitude.
Thank you, Shrenik. But you know what? You have given much more back to the society and the world, and God is, that's why you are blessed with Him.
Thank you.
True, sir.
Thank you. So, thank you so very much. And with this, we conclude the meeting. And sir, thank you so very much for your valued time. And by the way, if anybody needs supports in the Head&Neck Cancer, feel free to reach out to me. I will be more than happy to coordinate the appointment and other steps with Dr. Patel. Thank you so very much, sir.
Thank you, Shrenik, and thank you, Vaishali ji and Aruna ji.
Thank you, sir.
It was extremely happy to have you and talk to you. And Aruna ji, your very good point-wise questions. I really appreciate that. Thank you.
And
Thank you
you,
for the amazing
moderators,
session.
for making
It
good
was very
questions.
insightful.
Thank you. Thank you, Vaishali. Bye.
Good session,
Bye,
doctor.
bye.
Thank you very much.
Bye. Thank you,
Bye,
Aruna
bye.
ji. Bye.
Bye, sir.
Bye.